Welcome back to Oncology for the Inquisitive Mind, featuring none other than your co-hosts, Josh and Michael. Michael, how are you today?
I'm good, Josh, and I always appreciate you asking how I am when we start any recording.
I know, well, it's a nice thing to do, but today we're doing
It's the only time anyone does.
Oh, that's a little sad. I'll make sure I check in later after this episode. So we have a special ESMO review. We have the world-renowned Professor Anthony Joshua, not the boxer. The joke never gets old, but he's going to go through the pivotal trials that he thinks might be game changers, interesting in the GU space after ESMO. So, Mark and I love to wax lyrical about what we think is the best, but it's always great to have an expert. Anthony, thank you so much for giving up some of your very precious time to be on the show. How are you?
I'm good. How are you? Both of you.
Yeah, we're good. We're good. Thanks for asking. Well, why don't we get the show going, and we might interrupt you on occasion to ask, pick your brain some of the nuts and bolts of the GU world, which seems to be exploding at the moment.
Yes, it was very busy at ESMO. Caveat, I wasn't there, but I managed to obviously go through some of the trials. So happy to answer things to the best of my ability during the course of this talk, so feel free to interrupt. There was a lot at the meeting, so we could be here probably for a good 3 to 4 hours if we talked through everything that was relevant to clinical practice. So I have had to separate some stuff that was perhaps more practice changing from the other stuff which was less practice changing. So we'll sort of see the practice changing trials first, and then the other trials I'll just quickly go through at the end, and the other pieces of information. So here's some of the things that was exciting in terms of potentially practice changing. And I divided the prostate stuff up. There was a lot of prostate stuff. The prostate stuff up into high risk, locally advanced, so that's patch STAMPEDE, metastatic hormone sensitive, ARANOTE, and then the STAMPEDE arm, metastatic castrate resistant. That's all prostate. And then in bladder, we had Niagara and Ambassador in the perioperative and adjuvant setting, respectively. In kidney, we had the T-Nevo 2, just because I had to put something in about kidney. So now here we go, transdermal estrogens. This is the first one, the patch study, so high risk, locally advanced. So there's many reasons why, we'll start on the far right of the screen. There's many reasons why giving estrogen will reduce testosterone. It does basically shut down the hypothalamic axis in terms of producing testosterone, as well as acting directly on the testicle. So it acts at multiple points. The innovation here is it's topical estrogen, so it's not associated with the risk of thromboembolic events. And the other thing is, because it's estrogen directly, the side effects of lack of estrogen, which are a good chunk of the side effects of being castrated, do not occur. So the only effects you get are the lack of testosterone. So specifically, the lack of endogenous estradiol causes osteoporosis, lipid changes, increased fat deposition, increased insulin resistance, memory loss, and hot flashes. Whereas the suppression of testosterone is what causes the erectile dysfunction, loss of muscle mass, and muscle strength. So this study's been going on for a long time. It was separate to STAMPEDE, the patch study, and then it got put together in STAMPEDE as part of one of their arms, run by Ruth Langley, who presented the data at ESMO. And basically, they had 1,360 patients for transdermal estradiol versus LHRH for androgen suppression. This is just the locally advanced prostate cancer arm that was presented. The metastatic arm not presented yet. The patches were designed to release 100 micrograms of estradiol in 24 hours. 4 patches changed twice weekly, a bit like Krusty the Clown and his nicotine replacement. So quite a few patches to get those levels up. And there's a lot of data about how much estradiol you need to get that testosterone suppression. And men are randomized between LHRH and topical estradiol, primary endpoint metastasis-free survival in a non-inferiority design. And this is the results. The metastasis-free survival, you can see the hazard ratio 0.96, so met the boundaries of non-inferiority. If anything, it's almost impossible to tell those two curves apart. So it seems to be a reasonable option for men, at least as far as we have the information to date, for a locally advanced prostate cancer wishing to avoid the side effects of ADT. The metastasis-free survival being 86 versus 87%. So that's obviously nice to have another option for men. And the secondary outcomes here were, in terms of overall survival, also very similar. Maybe there was a slight benefit for actually the topical estradiol, but nothing we can point to. But you can see here there's a yin yang between the hot flashes and the gynecomastia. So the gynecomastia was usually not too bad, and probably could be managed successfully with a proactive approach in terms of prophylactic breast radiation and or potentially even oral tamoxifen. But mostly I understand that was mostly low-grade gynecomastia. So excellent to have another option for men to talk through in terms of the issues with castration, whether men will accept this, or if the actual, it depends on what their objection is to ADT in the first place, and that varies from man to man. But it's always good to have more options, and I think this is possibly, at least in this setting as it stands, a good alternative standard of care.
Anthony, I have a quick question. What's the rate of patients who refuse ADT? Do you have is there a number? Because in tamoxifen, etc., in breast cancer, it's about 30% that just won't tolerate adjuvant endocrine therapy, as an example. Is there sort of a percentage or a group of patients which you're trying to address this with?
So I have patients who refuse ADT, and we work as hard as we can to find alternatives for them and address the issues with regards to the ADT to a point. I don't know if I've ever seen any literature about the percentage of men who refuse ADT outright, but it depends on the setting of their prostate cancer, I think, and their age. So I don't know if I've seen that data, but certainly and there is some data in terms of some of this, in terms of hot flashes, how that relates to testosterone, the time to testosterone recovery. And the percentage of men that get severe hot flashes. There's nice data from the EMBARK study about how many men get gynecomastia with single agent enzalutamide or the doublet. So similar rates actually in terms of gynecomastia, but I don't know if I have an exact number for men who refuse ADT. I think in my practice is outright. In my practice is probably in the single digits.
Interesting. Yeah, just curious. Just a curious question.
Yes. Okay, so now moving on to metastatic hormone-sensitive disease. So this is the long-awaited ARANOTE study. And this is one of the slides, one of the discussants. I have shamelessly borrowed a lot of these slides. So these patients were randomized 2-to-1 to darolutamide plus ADT versus ADT alone. The point being that the primary endpoint was radiographic progression-free survival, as opposed to a co-primary radiographic survival and overall survival. Maybe that was driven by the urgency of getting some data dating back to the ARASEN study, which was done in combination with docetaxel. But this was this practice pattern with darolutamide and ADT, ironically in Australia, is probably the highest selling ARSI or ARPI. I think mainly because of its tolerability in advance, actually, of this data. That was a government decision, unlike other countries in the world. But nevertheless, we're waiting this data to understand what had gone on. So let's just look at who was enrolled onto this study. So these were patients predominantly who were de novo metastatic, predominantly, as it turns out, with high volume disease. So that does affect some of our interpretation of this study in terms of the result, which is here. So it does reduce the risk of radiographic progression or death by 46%. You can see there that at the 2-year time point, 70% versus 52%. Now, some people have looked at this and said they would like to see a bigger RPFS, but this sounds like it's a high-risk population, and the delta there is probably reasonable in that population, but certainly there's been a lot of discussion to say I would have expected more from the drug not as active as I thought it would be, and a bit of angst going on backwards and forwards. And this is the subgroup analysis showing that there was obviously benefit in low volume disease greater than high volume, again to be expected. There is the ARA-STEP study, which is looking at patients who have PSMA PET detected disease, which will probably have also be positive, but that's still accruing. And this is now looking at in terms of overall survival. The overall survival data is immature. Again, that caused a little bit of angst, I think, at the time, but trending in the right direction in terms of favouring darolutamide. I would certainly not be surprised if this does become significant over time. But the bar is higher now than it used to be because all these drugs are now available. So I would anticipate that most people on the control arm would in fact get one of these drugs, and that was not the case for some of the other trials. I think this data confirms the validity of current practice, both in Australia and perhaps elsewhere, where darolutamide can be used as an alternative ARPI in combination with ADT. Whether as a practitioner you have a bias in terms of using one ARPI or another, I think is up to local practice. I don't think there's any robust data to suggest that any one drug is better than any other in terms of efficacy, but in terms of side effects, you have to weigh those up with the patient at the time. So I certainly have patients who refuse to take pills twice a day, and have patients who are elderly and perhaps not suited to other drugs across the blood-brain barrier. So I think that's an individualized decision. But I think this data was long awaited and does suggest that darolutamide does have activity on par with other drugs. The side effects, obviously, it's well tolerated, as we know, between the two groups. And the only thing of concern here that I think was subject to one of the discussants, Dr. Vogel, was this bone fracture issue. So it does remind us that we do have to be very, very cognizant of bone health in patients on ADT, perhaps more so if they're on an ARPI, and be very proactive about monitoring their bone health. And this has come up through a number of studies recently to suggest the detrimental effect of testosterone deprivation on bone health. We have to monitor that closely. In Australia, giving denosumab is not reimbursed as a prophylactic bone health agent, but certainly I am very inclined to monitor my patient's bone density very proactively and to initiate treatment if needed. We'll come to that also in piece 3, but this is a concern and something that should influence the way we approach these men and be very proactive about wellness, including the need for resistance exercise in particular and bone health management, as well as cardiovascular risk factor management.
Anthony, just a question. You mentioned obviously the need to individualize the treatment of or the choice of a novel anti-androgen. In your, I guess, for want of a better word, a standard patient with no sort of risk factors, so for example, no cardiac or neurological risk factors. We've got 4 approved on the PBS for hormone-sensitive prostate cancer, I believe. Do you have a default that if there's no other sort of contraindications that you go for, and is there a particular reason that you reach for one over the other?
I don't really have a default. I discuss it. I discuss all the options with the patients, outlining. I may not go through all 4 drugs. It's probably easier in practice to use an ARPI versus a testosterone synthesis inhibitor, but I usually present them with a couple of choices of options and outline the benefits and side effects of each drug. So, and I think that's a reasonable thing to do. Some people feel more strongly or less strongly about agents. I usually just say, here's a couple of choices. It's like Coles versus Woolworths. You just got to choose one and just do your business there. So, yes, no, I don't think there's any right answer. To that question. Now, if we move on to metformin, so metformin has a long and tortuous journey in prostate cancer. I recently presented the MAST study in active surveillance, showing that metformin had no role in active surveillance. And then you can see here on this graph, again, shamelessly borrowed from one of the discussants, that there is a long list of predominantly negative studies of metformin in prostate cancer. This standard of care plus metformin was arm K of the STAMPEDE study, separated out into locally advanced versus metastatic. and they presented the patients with metastatic disease only. You can see here that patients were randomized to standard of care versus metformin 850 milligrams daily up to 850 milligrams BD, and could stay on it beyond progression. So these patients were, again, predominantly ADT plus docetaxel. That's only a small number of them got ARPI, which is, again, not necessarily contemporary practice and may influence part of our discussion. The primary endpoint of overall survival was not met. So metformin did not influence overall survival, but if you split it up, then in the high volume patients, then the hazard ratio was 0.79 with p-value 0.0059. So this was the opposite to what the STAMPEDE investigators anticipated. But now there's a lot of hand waving going on. This was not a pre-specified analysis, but at the moment, the sort of vague theory is perhaps these high volume patients are more metabolically disorganized, and perhaps the drug has more activity in that subset. But obviously, it's, again, mostly patients treated with docetaxel. Maybe that accounts for the benefit, but very provocative data and worthy of further investigation. And importantly, though, there was some of these metabolic parameters were also fascinating. So you can see there in the orange that patients who were on metformin just looked better. So weight down, glucose down, HbA1c down, total cholesterol down, LDL cholesterol down. So it does do wonders for a man on ADT. So that's the that's the data there, and I think we'll await the locally advanced data, which I think was planned for ESMO, but for some reason wasn't presented. So that will be very exciting to see how that pans out. This is some of the GI side effects. Not surprisingly, more GI side effects on metformin. It's well known to cause diarrhea and GI upset. Tends to settle. That's why there's the run-in as the dose goes up. And now moving on to MCRPCs. This is the PEACE-3 study. So this study was somewhat tortured by COVID and the ERA-223 study. So patients were randomized 1-to-1 to enzalutamide versus enzalutamide plus radium-223, which is generally very well tolerated. After 119 patients, bone-protecting agents were made mandatory because of the ERA-223 data suggested giving radium when there's nothing for it to attach to, i.e. no bone turnover because no active metastases. It just goes and sits in the end plates and causes fractures. So they mandated bone protective agents, and these are the patient populations. It took a long time to accrue there, as you can see across the top. Some patients had prior docetaxel, some had prior abiraterone as the study progressed. Most patients had most of their radium. It is generally well tolerated. We don't use that much of it in Australia because it's expensive and not on the PBS. But it is fairly easy to tolerate. To tell patients it's most like radioactive calcium, and most patients seem to tolerate it reasonably well. So this is the primary endpoint of radiographic progression-free survival. You can see there that there's definitely a benefit for radium-223 at 24 months, 36% versus 45%. With proportional hazards. But what's interesting is this overall survival, there was the curve inverted. Now, I don't think they quite know why the curve flipped over, but definitely a benefit for the combination ultimately. But that little hump there in the first 18 months is provocative, and I think will be further investigated. I don't think the investigators know just quite yet what happened during that time. Whether they were the first patients to go on the study who didn't have the bone protective agents or what exactly occurred, but that will await further downstream analysis and a final OS analysis into the future.
Anthony, sorry, I'm going to just interject here. This is a really interesting study and I loved it. But putting this into practice, let's say theoretically it shows, OS and everything that we sort of want from this study we get. In Australia, if you progress on enzalutamide in the metastatic hormone sensitive setting, essentially you're done, right? This is in the metastatic castrate resistant setting. So how would you utilize this data in a real world population if most people are getting an RPs or RCs really early on?
Well, that's a challenge. So at the moment, it's only really applicable to people who have MCRPC. So I think the message is, though, you may have heard the TALPRO-2 study was positive for overall survival a couple of days ago, that if you do have MCRPC, doublets and potentially triplets are better than single agents on top of the ADT. So whether that doublet is lutetium, or that doublet is a PARP inhibitor, or that doublet is radium-223, when your disease is at MCRPC, you probably need 2 drugs rather than 1. That's probably where we're going. Whether that paradigm can be extended further upstream in terms of HSPC will, aside from docetaxel, will depend on the agent, I think. And so it'll be very interesting to see how that plays out. There's the PSMA addition study, which is 6 cycles of lutetium. Don't know what that's going to show. There's some concerns that's just too much lutetium and not enough active cancer, akin to what happened with ERA-223. But we'll have to see whether the upfront PARP inhibitors, et cetera, give a benefit of sufficient magnitude in the short term to be prolonged out to the long term. Obviously, the challenge gets higher and higher, and the studies have to be larger and larger to get that benefit to persist. So, but this study at the moment has, I guess, historical interest. There are still some patients on ADT alone out there, but for whom this may be relevant. But there may be other drugs that give a larger benefit, at least in the Australian setting, not cost as much either. So here's some of the side effects. You can see not much was related to the addition of radium of any significant concern. Maybe slightly more anemia and neutropenia, which is not unexpected. Now, if you turn to lutetium, so we do have a couple of studies, the PSMA-4 study, which was lutetium versus a crossover ARPI change. And now we've got the phase 3 SPLASH study presented at ESMO, which used, you'll see a different construct, and again, an alternative ARPI. So you can see the 2 studies were a little bit different. The SPLASH used an INT construct. The dose was lower. There are some various reasons for that. And there had slightly different secondary endpoints. The control arm was dubious ethically, but I think the study was just designed as a proof of principle to see if they could replicate what Novartis had done. And to some extent they did. Here's the study, 2-to-1 randomization. And you can see the patient characteristics here, 276 on the intervention arm. Actually good ethnic diversity, generally 0 to 1. Some patients to be expected generally in terms of what sort of patients we would see. And here's the RPFS primary analysis with a large crossover there, but the RPFS showing a benefit, perhaps not as large as PSMA-4, but certainly present. And then if you look at the interim overall survival analysis, then you can see the hazard ratio almost looks like it goes the wrong way. But again, we saw this before, and we'll have to wait to see what happens over time, given this is, if you like, lower doses and fewer doses. So that it will be interesting to see how this matures, but certainly another potential option that may find its way to Australia, at least within clinical trials in the not too distant future. Then we go to bladder. So big news in the Niagara study. So this is perioperative durvalumab and chemotherapy. So neoadjuvant 4 cycles, adjuvant 8 cycles, compared to just chemo. And you can see here the pathological complete response rate in the updated analysis being 37% versus 27%, which precipitated further downstream analyses in terms of event-free survival now by blind independent central review being 67 versus 59%. And then importantly, the overall survival now demonstrating a benefit of durvalumab at 82 versus 75% at 24 months. So this is obviously very exciting in terms of potentially being a new standard of care. What part of this relates to the adjuvant component? What part of it relates to the neoadjuvant component? I think we'll only find out with the passage of time and the number of trials trying to deconvolute that. And on that note, whatever you do, it has to be well tolerated. This was well tolerated in terms of the side effects, so I don't think there was anyone who came to any great harm from durvalumab, and a lot of patients did very well in terms of no one really had to discontinue the durvalumab. So that slide went out of place. Excuse me. So the conclusion of Niagara study is that it does support perioperative durvalumab with neoadjuvant chemotherapy as a potential new standard of care. I think this will be very rapidly adopted across the world where durvalumab is available, and it will certainly influence how we manage these patients in the perioperative setting.
And Anthony, sorry, with Niagara, I guess the question that leads on to that, obviously, as you say, this is a fantastic study and liable to become standard of care wherever you can get durvalumab. In the case of the patients who do recur, how do you think this is going to have a downstream effect on what we do? Do you think we're going to go to things like EV by itself, or have you seen any data that indicates some efficacy for a re-challenge in some capacity of immunotherapy if we're using durvalumab up front?
So that's a good question. I think it depends on when they relapse. So, if it's during the adjuvant component, then the PD-1, PD-L1 blockade probably not useful to hit again. So then you probably would have to move on to EV as a single agent, although there's some reason to believe that EV may also have some immunogenic properties, and if you give it with a checkpoint inhibitor, we'll see. But as I'm about to tell you with the kidney cancer data, giving IO after IO in some cases is most likely to be futile. So it sort of depends when and whether the T cells, if once you block the PD-1 and the PD-L1, will have that on them for a number of months. So it sort of depends on when this relapse occurs as to how that relates to the PD-L1 axis. So there are more studies coming in this space that will, I think, help us to understand what we should do next and how we should do it. So it would likely be something with EV, although re-challenge is not out of the question if there's been probably 6 months from the last dose. So I think there'll be some caveats around that. In terms of the kidney now, to sort of bring it home, so this study was TiVo versus Nivo, and notice the dose is different. That was because nivolumab, at least in population data, causes hypertension. So the FDA were somewhat adamant that because TiVo also causes hypertension, that has to be somewhat abrogated. Whether using the full dose of TiVo on this arm, and the other arm, the intervention arm of the study, would have made any difference? Probably not. In this setting of locally advanced kidney cancer after progression on 1 or 2 lines of therapy, but nevertheless, this is where we are. And this was the second trial to look at this question in terms of IO after IO, and perhaps there was some more enthusiasm about this approach, but it turns out no. So sequencing checkpoint inhibitors did not improve PFS. Probably a lot of these patients still had effective checkpoint blockade. It's a matter how you cut it. There was no clear signal that actually this was a beneficial approach. The TiVo is quite active in and by itself, and the IO didn't do much, and nor did it improve overall survival. So, although this is sort of immature data, so that's an important negative study. So not obviously affecting practice, but telling us what not to do, because at least in the United States there was a gestalt to just keep going with the IO, and no one had actually tested that theory. So these are the things I could not discuss. Where's my slide gone? Great. So these are things I couldn't discuss. So the upfront PSMA, well done, Dr. Azad, who demonstrated that two times doses of lutetium docetaxel ADT superior to docetaxel ADT for an endpoint of undetectable PSA at week 48. That was a very good, important conceptual breakthrough. The study forecast study for non-clear renal cell carcinoma showed ipi-nivo is better to TKI, predominantly Sutent, with a 12-month OS being 86.9 versus 76.7. The LightSpark 005 study showing belzutifan is superior to PFS but not OS for patients with refractory renal cell carcinoma. The Ambassador study showing that adjuvant pembro is superior to placebo post-neoadjuvant chemotherapy metastatic muscle-invasive bladder cancer for DFS so far has a ratio of 0.73, akin to Nivo. And the Sunrise programs, which is the gemcitabine pretzel. The data at ESMO was actually the second line, which is that Sunrise 4, TAR-200 plus atrilimab neoadjuvant showed a pathological complete response rate of 42 versus 23%, pathological overall response rate of 60% versus 36%, and the data that came out a week after ESMO was the Sunrise 2 program that showed that TAR-200 plus atrilimab did not show superiority to chemoradiotherapy in muscle-invasive bladder cancer for patients ineligible for cystectomy, and that study was halted. So exciting times, I must say. A really good dump of data and kept everyone thinking for quite some time. So I hope that's been helpful in terms of to you and to your listeners to understand where we are. And any questions?
I think that was great. I'm going to say long gone are the days of only having docetaxel as the really pure single option for prostate cancer and even bladder cancer. I think it's becoming a much more complex field. Michael and I just want to say thank you for sharing in your bounteous, that's the wrong word, but never-ending wisdom, Anthony, to tell us about the world of prostate and GU cancers, and we look forward to bringing you back for every single other global conference known to man. GU. I'll lock you in now, but have a great week.
We'll send you the contract fairly soon, Anthony.
That's it. It's all free of charge, unfortunately. But
that's right. That's right.
Some FaceTime with us is always great. But look, have a great week.
That's worth its weight in gold. FaceTime with you guys.
Thank you so much.
Exactly. That's what we tell everyone. Have a great week. See you later. Bye.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.